So this is a 34-year-old female. She has a history of preeclampsia. She did not tell us about the mitral valve prolapse, but we found it in her records later on. She presented to the ED. She was on her postpartum day 3, and she told us that she has been having this worsening chest pain, pressure, and shortness of breath that started earlier that morning. She was discharged 2 days ago from the hospital after an uneventful delivery. She did endorse that she had some cough. She had worsening leg swelling. She had worsening symptoms when she was lying flat. And she said that the symptoms have gradually worsened over a day, so much so that she is short of breath even at rest. So I want you to just think about this, because I'll ask you how would you classify these symptoms later on when we are talking about the classifications. So what would be your initial approach when you see a patient like this? Obviously, there would be plenty of other differentials, but for top differential here, one of them would be acute heart failure. So first things first, a thorough history and physical examination. You need to determine if there is any cause, any precipitating factor that led to this acute exacerbation of heart failure. Second, you need to assess how the patient is, what's their perfusion, how much congested they are, if they are in a state of shock. So those things you need to assess. You need to assess their overall hemodynamic status. You need to see if there are any other comorbidities that are playing a role in this exacerbation of heart failure. Then you need to order some blood work, some imaging studies. We'll go over them in more detail in a little bit. So the signs and symptoms of heart failure are basically clinical evidence of congestion, how much congested or how much fluid retention they have. The biggest symptom that they will present with is exertional dyspnea. It is a highly sensitive symptom. So it means that almost all patients who have heart failure would have exertional dyspnea. The other symptom that they would have, which is pretty specific to heart failure, is orthopnea and paroxysmal nocturnal dyspnea. They are pretty similar in their mechanism. The only difference is orthopnea, you'll feel short of breath right after you lie flat, and you would just want to get back up and sit upright. Paroxysmal nocturnal dyspnea, you would go to sleep, and then you'll be sleeping a couple hours, and then all of a sudden you'll wake up short of breath, and that wouldn't resolve that quickly. They're both highly specific for heart failure. So a person who has exertional dyspnea, orthopnea, or PND, the differential of heart failure is pretty high for those kind of patients. The other symptoms they can present with is lower extremity edema, jugular venous distension. That is, again, pretty specific for heart failure. On your physical exam, you can have some murmurs in the heart. You can listen to fine crackles or rales in the lungs. Those are the things you need to assess for every patient when you see who have a suspicion of having heart failure. Investigations. All the investigations listed here are from ACC/AHA. They are class 1 indications for someone who is coming in with heart failure. So CBC. One of the precipitating factors for heart failure is anemia. So you want to do a CBC to make sure they're not anemic. CMP, they specify creatinine, BUN, LFTs, and electrolytes. The one test that we order here is CMP, which covers all of them. You need to make sure they are not in AKI, they don't have a cardiorenal picture, they don't have a shock liver, they don't have ischemic hepatitis. Their electrolytes are fine because you want to diurese them. You want to make sure that their electrolytes are okay. Urinalysis. I was kind of surprised when I saw urinalysis there, but I was reading on it, and urine albumin to creatinine ratio is an independent risk factor with heart failure readmissions. And this is like a prognostic marker. If you have a high urine albumin to creatinine ratio, it's a poor marker for overall long-term prognosis. Lipid panel, obviously, it's like the biggest factor in cardiovascular disease. Iron studies, even if the patient is not anemic, research has shown that if we supplement iron for iron deficiency in acute heart failure, it reduces the risk of readmissions. This is one of the QI projects that you might have seen in our hospital that we are doing. Glucose or HbA1c, you want to make sure they are not diabetic, and if they are, it is well controlled. BNP or NT-proBNP, they're essentially the same. We just use NT-proBNP in our hospital. This is a surrogate and objective evidence for congestion. This is the one lab test that you must do for someone who is coming in with acute heart failure, because the higher the proBNP, the higher the congestion they would have. Two things to keep in mind for this. This can be falsely elevated and falsely low. For patients who have kidney issues, CKD, acute renal failure, AKIs, it can be falsely elevated. For patients who are obese, it might be falsely low. These are the two populations we tend to see a lot in our hospital. 12-lead EKG, you need to make sure they don't have any arrhythmias. Chest X-ray, you may need to make sure how much congestion they have, how much pulmonary edema, if there is any pleural effusions, those kind of things. A transthoracic echocardiogram, you should order it if there is no echocardiogram done recently. If they do have an echocardiogram done within the last 6 months or a year and there hasn't been anything drastically different in the last few months, I would not do another echocardiogram. You have a question? Yeah.
About the
It's some people do trend it, but from what I have read and what I have observed, you don't really need to trend it daily. It is a good practice, though, that you do a repeat proBNP once the patient has been diuresed adequately and you determine that they are at their dry weight, because that would be their baseline proBNP, and that helps you in determining the severity of congestion or heart failure if they were to get readmitted later on. Mm-hmm. Mm-hmm. Okay. Any other questions? All right. So these are pretty much the main investigations that we are looking at. Precipitating factors. For our patient population, the biggest one would be non-adherence or non-compliance. You'll send them on medications and they'll come back. They wouldn't be compliant with their medications. Uncontrolled hypertension, that's another big one that we tend to see a lot in our hospital. Acute coronary syndromes, if they have NSTEMI, STEMI, angina, they have active ischemia going on in the heart, that can worsen the heart failure. Atrial fibrillation and other arrhythmias. Atrial fibrillation, it is especially important in patients who have heart failure with preserved ejection fraction. We'll talk about that a little later because they are really dependent on the atrial kick. If you lose that, this tends to worsen heart failure in those subset of patients. Acute infections, anytime someone is septic, their cardiac output needs to go up because of the increased metabolic demand, and that itself can precipitate heart failure. Anemia, again, the same concept. The heart needs to work more because your oxygen carrying capacity is low. That can precipitate it. Hypo and hyperthyroidism, they both can do it. Medications, we tend to forget about medications. Most common ones being NSAIDs. They should not be used in patients who have heart failure. calcium channel blockers. Even nifedipine is not recommended in patients who have heart failure with reduced ejection fraction. So we'll talk about a few different ways you can classify heart failure. Uh, does anyone know which views of echocardiograms these are? Yeah, yeah. So these are apical 4-chamber views, two very different types of heart failure. So the one on the left, if we can point it out. Yeah, this one. So this one, you can see that the heart is pumping very nicely. So the ejection fraction per se for this patient is normal, at least more than 50%. The one on the other hand, here you can see that the heart is not pumping that well. And if I can show you here, so this is the LV, this part. This is the left atrium. This is the right ventricle. And this is the right atrium. Here you can see is the mitral valve. The one good way of assessing ejection fraction, if you haven't really seen a lot of echoes, is you can see the motion of the mitral leaflet. Usually when the ejection fraction is normal, the leaflet would hit all the way to the septum, like in that one. But when the ejection fraction is low, it will maybe go a little bit, but wouldn't go all the way to the septum. So this one is heart failure with reduced ejection fraction, and the one that is pumping well is heart failure with preserved ejection fraction. And we'll classify that, we'll go over that a little more. So we talked about reduced ejection fraction. It is heart failure with EF equal to or less than 40%. Heart failure with preserved ejection fraction is EF equal to or more than 50%. Anything in between is heart failure with mildly reduced ejection fraction. Sometimes you'll have patients who had heart failure with reduced ejection fraction. They had a EF of less than 40%, and then you started them on guideline-directed medical therapy. You fix their heart. Those, when their EF improves, they are called heart failure with improved ejection fraction. So you will see all of these terminologies written in your notes, and this is how you will be documenting as well. NYHA classification. So I think almost all of us are familiar with this, but this is one good way of classifying heart failure, because this really tells, the moment you say class 1, 2, 3, or 4, it automatically tells the person how bad the symptoms are for their heart failure. Everyone essentially qualifies for class 1. There is no limitation in physical activity, no symptoms with ordinary activity. Class 2 would be someone who is walking from or parking lot to or lounge, and they will develop dyspnea. Class 3 would be someone who is going from his bed to the restroom, and now they started having dyspnea. And class 4 would be severely limited. They would have dyspnea even at rest. So this is just the basic concept of this. And it is always a good habit to write what NYHA class they are when you document the type of heart failure. ACC and AHA, they classify heart failure in a different way. And this is essentially based on the severity of heart failure. So stage A is a person who never had symptoms of heart failure. They do not have any evidence, any structural evidence, any biomarker evidence. The only thing they have is they have a risk factor. They could have diabetes, they could have obesity, they could have cardiovascular disease overall. They could have, maybe they could be on a chemotherapy agent, which is toxic, maybe anthracyclines or something like that. But they do not have any evidence of any structural heart failure, or any of the biomarkers that we use. Stage B is someone who, again, does not have any signs or symptoms of heart failure. but they do have some evidence of some structural defect somewhere, or they may have some elevated biomarkers for them. Stage C is someone who is coming in with signs and symptoms of heart failure. And stage D is someone who had heart failure and their activities are severely limited because of worsening heart failure, and they have to have frequent hospitalizations. So now that we have talked about these two classifications, what do you think for a patient who initially presented, how would you classify their heart failure? So that patient had symptoms even at rest. So her heart failure, you would say NYHA class 4. And then when we say she has a history of preeclampsia, that automatically puts her into stage A. She has a risk factor. When we said she has a mitral valve prolapse, that's put her into stage B. She has a pre-heart failure. And now when she presented to us, she had signs and symptoms of heart failure, so she is at a stage C. So that was NYHA class 4 and ACC stage C, heart failure. I want to spend a little bit of time on this one. So you will come across these classifications a lot. Forrester-Stevenson profiles, they were initially developed by these scientists, and this was based on data that they gathered from patients who had the Swan-Ganz catheters. They took this data and they divided the patients into 4 broad categories. On the vertical axis, the y-axis, what you see is perfusion. They measured perfusion based on cardiac index, which was an invasive direct measure of your cardiac output. On the x-axis or the horizontal axis, they were measuring pulmonary capillary wedge pressures, which is essentially the pressure in your left atrium and is a marker for congestion overall. But those were invasive measures, and nowadays we don't tend to put Swan-Ganz catheters in all the patients who are coming in. So we usually use here non-invasive markers. So for perfusion or cardiac index, what you can use as a surrogate is mean arterial pressure. And for congestion, what you can use is the pro-BNP levels. Again, keep in mind that the pro-BNP could be very different from what it actually might be based on their renal function, their obesity, and all of those things. So 4 different categories. So profile 1, this is a patient who has good perfusion and they are not congested. This is the patient who came in with heart failure and now is ready for discharge. So this is the patient you might see in your clinic on your TCM visit. They came to the hospital, you fixed them, and now they are going home, they are dry, and they are well perfused. This is what your goal should be when you discharge a patient. Profile 2 is kind of tricky. These are patients who have low perfusion, but they are not very congested. We tend to see them, but they are few and far between, typically with advanced heart failure. They tend to require some inotropic support, but this is only maybe 5 or 10% of the heart failure patients you would actually see in the hospital. They tend to have very low ejection fractions, low cardiac outputs, and they could be symptomatic even with a very mild amount of congestion. Profile 3 is the classic heart failure patient. This is perhaps what our patient was when they came in. They are well perfused, but they are very congested. Their pro-BNP is high. You examine them, and they have several data points that point towards being congested. These are the patients who you want to diurese, and you want to diurese them well. Profile 4. This is the person who has poor perfusion and who is also congested. We have a patient like this in our team right now. These patients tend to require diuresis as well as inotropic support sometimes. And we have exactly this patient here. And they tend to be the ones who might go into cardiogenic shock, who might need ICU level of care. And these are the sickest ones. Now that we have sorted out how we classify and how we think about heart failure patients, or let's talk about what our goals should be when we are about to treat or manage them. So our goal should be, again, based on the Forrester classification, assess congestion and perfusion and optimize their volume status based on their hemodynamics and the level of congestion they had. Again, based on your history taking, identify any precipitating factor if they existed and try to address those factors. And then we'll talk about GDMT, guideline directed medical therapy. We should either continue, resume, initiate, or uptitrate GDMT. Heart failure topic or talk does not go without GDMT. We'll be discussing that in a little bit. So management of congestion in heart failure patients. So typically, most of the patients that we get in our hospital, they would already have a diagnosis of heart failure that was established. So what we generally tend to do is if they were taking 40 milligrams of Lasix at home, PO, you increase that dose to 2.5 times. Generally, the dose that you would see here in the hospital would be 40 milligrams IV of Lasix twice daily, once in the morning, 6 a.m., and then one around 4 or 6 p.m. Once you have given them the diuretic, you need to assess how the diuretic is working and how the patient is responding to the diuretic dose. You need to assess their I's and O's, how much total urine output was there and what is the net negative for that patient. You need to make sure the nurses are documenting that accurately. You need to monitor the standardized daily weights. Now, the word standardized here is important because sometimes in our patient population, sometimes the weight they would have charted would be a bed weight, and the other times it would be a standing scale weight. So it should be either one of those, ideally. Ideally, the standing scale weight. Then whenever you go in to see the patient, you have to assess all those signs of congestion that we already talked about. And you have to assess if they are well perfused or not. And then the labs that we need to monitor mainly are electrolytes, creatinine, BUN, because we want to make sure all of these numbers are good. Once you have monitored all of these numbers, you have to decide if they are diuresing adequately or not. If you think they are diuresing adequately, you can continue the same diuretic dose and assess further. If you think that the diuretic dose is not enough and they need more diuretic, there are a few options that you can use. Number one is you just double the dose that they were on. For example, if they were on 40 milligrams IV Lasix BID, you go to 80 milligrams IV Lasix BID. If you are not comfortable doing that, the other option is you can put the patient on a Lasix infusion, 10 milligrams per hour, or 15 milligrams per hour, or 20 milligrams per hour. The maximum dose of Lasix per day is 600 milligrams per day. So anything below that, you can theoretically go. The third option, which I personally like, is you add a sequential nephron blockade. And we'll discuss that in the next slide. And then once you have done that, you again monitor the whole thing again and decide further. Once they are, like Dr. Rumsicle mentioned, once their pro-BNP is maybe less than 50%, or just based on your assessment, their congestion has gone down significantly and you think they're back to their dry weight, you can stop the IV diuretics and switch them back to oral and then go from there. So sequential nephron block, what happens is when we are, so these are different medicines that act at different part of the nephron. So we typically tend to use loop diuretics. They are the class 1 recommendation to be used in heart failure patients. They will work on this part in the loop of Henle, and then the residual flow will go in the distal convoluted tubule, and then from there it will eventually go into the urine. What happens if you are removing a lot of fluid from this part, the distal convoluted tubule, they tend to reabsorb all the fluid back. And then you end up not making as much urine as you want. And this tend to happen in those patients more frequently who have been on diuretics in the past. So someone who is diuretic naive, just the loop diuretic might be more than enough. For someone who has been on diuretics chronically, loop diuretic might not be enough for them alone. So you need to add something that acts on a different part of nephron. The most potent one when combined with the loop diuretic is a thiazide diuretic. They work on this part, the distal convoluted tubule part. So now here, all the fluid has been pumped into this distal convoluted tubule, and it is low in salts. So a normal DCT would tend to reabsorb the fluid back into the blood. But when you block this part, you will get a very aggressive diuresis. One of the medicines that we typically use here in the hospital is metolazone. It is a very potent medicine, and you will see patients would easily make urine output more than 5 liters, up to even 10 liters, by just adding 1 dose of metolazone on top of the loop diuretic dose that you are already giving. We typically tend to use it together here, but I haven't really read about if there is like a particular timing. But you should be on a loop before adding metolazone. You don't start with metolazone. Okay.
Metolazone maybe 1 hour later.
Okay.
But in the hospital, nurses usually give both.
Yeah.
But you have to give.
Anytime you're trying to time anything like that, you should tell the nurse. You might order it like that.
Yeah.
Because anybody that daily comes at 9 a.m.
Mm-hmm.
If you want to time it, you have to put time
Yeah.
at 8
Mm-hmm.
a.m.
Yeah. Also because they give the loops around 6 a.m.
Loops are
So
because it's a morning. 6 and
6 and 4. All right. So the other medicine that I want to point out here is acetazolamide.
I don't know whether it's pathway later maybe.
Just a little bit. I'll touch base on that.
Yeah, because now the policy is the diuretics.
Yeah, I'll go over that. Mhm. That's my QA project. So I'll mention that. Yeah. No. Yeah. No, I'll go there. So the other medicine is acetazolamide here. This is a carbonic anhydrase inhibitor. Sometimes when you are diuresing patients a lot, they will develop contraction alkalosis. Their bicarb would go high. If it is more than like 34, 35, you can add acetazolamide. It helps both in bringing the alkalosis down, as well as it helps with further diuresis as well. So we haven't discussed about the urine sodium part so far, because this is not in the American cardiology guidelines anywhere. This has been adopted in the European guidelines already. And I want to show you here the role of urine sodium in monitoring diuretic response. On this first graph on the left, yes. So on the y-axis, you see the percentage of death or hospital or readmission. And on the y-axis, you see the number of days. And the color coding, the blue, just focus on the blue, on the sky blue one and the purple one. I'll call this purple, but I'm not sure. Maybe girls know better which color this is. But for me, the sky blue one is the top one and the purple one is the bottom one. So you can see that the two lines, they split apart pretty early. The top sky blue one is a urine sodium of less than 50, and the bottom purple one is a urine sodium of more than 100. So for example, at 30 days, a person who was making a urine sodium of 100 had a 50% or even less risk of death or hospital readmission compared to someone whose urine sodium was less than 50. So this is something that is being incorporated into guidelines, and more research is being done on this, that urine sodium should be utilized as an objective data point in monitoring diuretic response in heart failure patients. And the good part about this is you will come across this a lot, that the nurses might not have documented the urine output correctly. Patient might be drinking 3-4 liters of water and no one really knows about it. None of this would really affect the urine sodium part. This would be an objective data. The only caveat with this is this should be measured ideally 2 to 4 hours after giving the diuretic dose. For example, if the loop was given at 6 a.m., this should be collected at around 8 a.m. to 10 a.m. That is where the concentration of the Lasix is the highest in the body. The other graph shows the length of stay for based on how much your urine sodium was. Long story short, the higher the urine sodium is, the lesser your length of stay is. This has been demonstrated in multiple studies. This is the poster you might have seen a lot in our lounge, in other dictation rooms. This is one of the QI projects that we are doing about timely effective diuresis. This is the pathway that they've initiated in the hospital as well. Yes. And I think now the emergency people, they are already putting this. Yeah. Guideline directed medical therapy. This will be talked about a lot in the rounds. There are some medications and some therapies that have proven to be to have some mortality benefit in patients with heart failure. They are all pretty much listed here. 4 main medications: ACEs or ARBs. They have proven to be effective in reducing mortality. The number needed to treat standardized for 36 months of mortality data is given in the last column. So number needed to treat for ACEs or ARBs is 26. For ARNIs, which is sacubitril and valsartan, its number is 27. For beta blockers, it is 9. For beta blockers, this number is for heart failure with reduced ejection fraction only. MRAs, the number is 6. SGLT2 inhibitors, the number is 22. Hydralazine combined with nitrates, this is used in African American population mainly, and this should be added once the rest of the GDMT has been optimized. This isn't the first line medicine that we use. The number needed to treat for this one is 7. Mm-hmm. Yeah. Yes. CRT is cardiac resynchronization therapy. And this is for patients who have a wide QRS complex, left bundle branch block, and heart failure with reduced ejection fraction. Number needed to treat is 8. ICDs, again, for heart failure with reduced ejection fraction that has not responded to GDMT despite 3 months of GDMT. Number needed to treat is 23. One question that you will be asked a lot, especially Dr. Brink likes to ask is which beta blockers are a part of GDMT? Do we know? Yeah, so bisoprolol, carvedilol, and metoprolol succinate, not metoprolol tartrate. Succinate is the longer acting form of metoprolol. These 3 beta blockers have been studied and have shown mortality benefit, but they're all for heart failure with reduced ejection fraction, not for heart failure with preserved ejection fraction. And that I didn't know. Okay, so nebivolol as well, if you're in Europe. Where are we in terms of time? This is like this is a busy slide, and I'm not sure if everyone is like alert oriented enough to go over this, but I think this was, I took this from the ACC AHA guidelines from 2022, and this one slide sums up the entire management of heart failure with reduced ejection fraction. So we'll go from left to right. As we move from left to right, like step 1 till step 6, your patient is becoming sicker and sicker. So a patient who has a diagnosis of heart failure with reduced ejection fraction, they have symptoms, they come to the hospital, so we have to do whatever is there in column 1. Diuretics as needed. We have to optimize their GDMT, which would include ACEs or ARBs, beta blockers, MRAs, SGLT2 inhibitors. You optimize them, titrate these medications as much as possible, as much as they can tolerate, and then reassess. One of the 2 things could happen. Their heart failure would improve, their EF improves, and you just continue the GDMT they were on. If their EF stays low, we'll call it persistent heart failure with reduced ejection fraction. There are a few more things that are listed in step 3 and 4 that you can do. If the patient is African American, you can add hydralazine nitrate combination. It comes as under the brand name of Bidil in the market. You can add that. If it's dinitrate. Yeah, it's dinitrate. Hydralazine and isosorbide dinitrate. If their EF is less than 35% and their survival is more than 1 year, and they have been on GDMT for more than 3 months, you should put an ICD for those patients to prevent a risk for sudden cardiac arrest. Now, if they have a QRS complex of greater than 150 and with the left bundle branch block morphology, that is a class 1 indication for cardiac resynchronization therapy. Even if the QRS complex is more than 120 milliseconds, it is still a class 2A recommendation to have them on CRT-D. Now, you did all of these things as well. If the patient still has worsening heart failure, now at that point, they would be the stage D heart failure, where the patient is having severe limitations in their daily activities. They are coming back to the hospital very frequently because of their heart failure exacerbations. So those patients, if they are a candidate for transplant, you can put them on mechanical support devices, for example, the LVADs. They are a temporary measure or a bridge to transplant, but that you can only do if they are a candidate for transplant. If they are not, because of 10 other problems, the only other option is palliative care for them. For heart failure with mildly reduced ejection fraction or heart failure with preserved ejection fraction, the GDMT part is pretty much the same, except that the level of recommendation is relatively low. So we saw all of these GDMT medicines, they were listed as a class 1 recommendation for heart failure with reduced ejection fraction. For heart failure with mildly reduced or with preserved ejection fraction, only diuretics are the strongest, have the strongest recommendation. SGLT2 inhibitors are reasonable, and the other medicines are maybe reasonable. One thing that I want you to see here is that for heart failure with preserved ejection fraction, you do not see beta blockers. So beta blockers are not a part of GDMT for heart failure with preserved ejection fraction. And that is because in preserved ejection fraction, your heart is not filling well. The only way it can increase cardiac output is by increasing the heart rate, essentially. So if you put them on a beta blocker, you have taken away the only compensatory mechanism from the heart to increase its output. Lifestyle modifications, they should be always recommended to any patient who has heart failure. Regular physical activity, maintaining a normal weight, healthy diet, avoiding smoking, alcohol, and if they are having symptomatic heart failure, you should limit the dietary sodium to less than 2 grams per day. Now, we have pretty much discussed most of the information that we needed to have. Now we'll just go over the heart failure order set that we use in the hospital, and it would be essentially everything that we have just talked about. You will see a lot of these advisories that will pop up when you're trying to put in an order. They are usually asking you to put in the heart failure order set. Sometimes you would have put all the orders, but just not the heart failure order set. So I'll show you how that looks like. So you just type in heart failure in your place where you usually type orders, and it will open a heart failure panel. The heart failure panel, it will have some orders for nursing. The initial orders for nursing are essentially what we call the monitoring. So strict I's and O's, weighing the patient, CHF education, tobacco cessation education. These kind of things would automatically pop up. Next, it will ask you for respiratory interventions. It will have you decide if you want to give them supplemental oxygen. Sometimes your patients may need it, sometimes they wouldn't need it. It will ask you if you want to put in any consults. Generally, you would need a cardiology consult. You may or may not need it, depending on how bad the heart failure is. So it will give you these labs. So the labs are pretty much the same that we have discussed so far. The only thing that I do not see in these labs is iron studies that you should do but are not a part of heart failure order set. Imaging, it will automatically take you if you want to do any chest x-rays, an EKG, or a transthoracic echocardiogram. If they had an echocardiogram done recently, you should not order an echocardiogram and let cardiology decide if they want to do it. If no echocardiogram was done previously, it's reasonable to do an echocardiogram for those patients. And then it will ask you which medications you want to start. So again, loop diuretics, thiazide diuretic would be a second line medicine that you might add if you think they're not responding appropriately to your initial diuretic regimen. And then diuretic infusion is also something that you might have to use when you are escalating the therapy for them. Guideline-directed medical therapy, again, all of the same medications, beta blockers, ACEs, ARBs, ARNIs, MRAs, SGLT2 inhibitors, vasodilators, whichever one they are using, you want to add. You should slowly add them because sometimes if you add them all together, their renal function might take a hit and then you get so worried that you might have to stop them. It is not generally recommended to pause GDMT for a small change in creatinine or GFR because that is expected in the first 48 hours. And this is usually reversible. Key takeaway points. Whenever you have a patient with heart failure, try to look for signs and symptoms of congestion. They would be telling you how bad the heart failure is for that patient. Try to identify the cause as to what caused the patient to go into this exacerbation of heart failure. It could be non-compliance, could be arrhythmias, it could be sepsis, could be anything, and try to address that cause. Order high-yield investigations. Pretty much all of the investigations that we talked about, they're all class one indications, except for echocardiogram, which you have to decide if you want to do it or not. Use the heart failure order set because that is how our hospital tracks patients who have heart failure, and then you wouldn't miss any orders with that. Assess the response to diuretics, order a urine sodium, and optimize GDMT as much as you can. So that's pretty much it. If you have any questions, please let me know. So you have to, again, assess for the congestion. If they came with a JVD, if that has now resolved, if they came in with freckles all over the lungs, if now the lung sounds fine, if they had 3+ edema in the bilateral lower extremities, if that has resolved, the proBNP, if you are checking it, if that is trending down. So all of these markers, if their symptoms, their shortness of breath, their dyspnea has improved, all of these together combined would tell you if the patient is ready to be discharged or not. There is no one criteria that you can say, okay, we have done this, so the patient can be discharged. It would be the overall clinical picture.
Most important is off oxygen too, right?
Yeah.
Some new,
Yeah,
new
but
evidence,
yeah.
maybe you've heard about this too. If you do an ultrasound of the lung,
B
and I
line.
think it's less than 15 curly B lines, something like that. That predicts better outcomes and readiness for discharge, or something like
that would, yeah.
5 or 15.
Focus is one of the emerging diagnostic methods that we can use.
That should be.
Yeah. How they feel. Yeah. Mhm. Mhm.
That's good for any COPD or pneumonia. Do you feel ready to go home?
I have a question. You said that if they have an echocardiogram from previously, there's no need to RN now.
If it was done recently and there has been no change in, like if they didn't have a STEMI or an STEMI recently after that echocardiogram, I wouldn't order it. You would let cardiology decide if they want to do it or not.
How,
Yeah.
Even
Yeah.
if it is done 3 years ago, you
Yeah.
have to do
Mhm.
it. If it's a new and STEMI, you do again.
Mhm.
If it's a stroke,
Yeah. It shouldn't be done just because you want to see the LV function and you don't have any plan in mind. You shouldn't probably do it.
The admissions, for how long iron study will we?
That is a good question. I'm not sure how frequently you need to recheck the iron studies for a patient who is getting readmitted. Mhm.
There is now emerging data that's robust. So the iron studies primarily should be done. And the way you treat it is not oral iron, it's actually IV iron.
Mhm.
So sometimes we give one dose in the hospital and then we finish off the remaining.
Yeah.
Do they do iron infusions in our primary care clinic or they have to come to Hematal?
No,
Yeah.
I think we just schedule them with the infusion center.
Yeah.
Oh,
So you can order outpatient infusion like you would do on blood, yeah, you could order out. And then for like Prolia, we send to the infusion center.
okay.
Yeah.
You can order from the here to
Yeah, we have one more question. Mhm.
About GDMT in patient, for example, if you had a patient who compliant with his previous GDMT and has a exacerbation, we just continue his previous regime and add something additionally. And if the patient not compliant, how you use it?
So your goal should be to have them on the maximally tolerated GDMT. Now, if they are on maybe 2 medicines, you ideally want them to be on all 4. So beta blocker for heart failure with reduced ejection fraction, you want them to be on beta blocker, MRAs, SGLT2 inhibitors, ACE, ARB, or ARNI, one of those. And then if they are on all 4 and they are on low doses, you want to up titrate the doses to the maximally tolerated doses where they can go. Now, if you have done all of that and they are on the maxed out doses of all 4 of these medications and they are still having heart failure readmissions, then you go to step 3. That is where you think if they are African Americans, you can add the hydralazine isosorbide dinitrate combination. If they have a good survival and their EF is still low despite being on GDMT, you might have to put an ICD. If they have a wide QRS complex, you might have to think about CRTD because that can also increase the ejection fraction pretty well at times. And if you have done all of that as well, you have to pretty much assess if they are a candidate for a heart transplant or not. Yeah, so if you have heart failure with reduced ejection fraction and your heart rate is still kind of on the higher side, typically you can add it for heart rate more than 70. If your heart rate continues to be on the higher side despite being on the maximally tolerated beta blocker therapy, you can add another medicine called ivabradine. It's a funny channel blocker. It essentially slows down the SA node. And then that is also one of the newer medicines that is recommended for heart failure with reduced ejection fraction. Yes. Scoring system is Dr. Abdullah's. Yeah. Yeah. So I'll have him talk about the scoring part.
Never optimize on the GDP,
Mhm.
almost never. So, the way we can do it is there's a way that you can do it objectively and then the subjective way. So subjective is you can think that, okay, this patient has high AFib burden or high arrhythmia burden. I can maybe prioritize putting an MRA for because MRAs reduce AFib burden and they actually reduce sudden cardiac death by 30%. You can think these patients have kidney disease, so maybe we'll put them more in ASR or an SGLT2. Those patients have an ischemic background, so you could maybe think I'll put them on a beta blocker or an ASR. So that's all subjective. Now there's more new scores that are emerging. The first study that I saw was actually done in Japan and was published in the European Society of Cardiology. And what they do is that they grab every category of GDMT medication and they give it a score based on the importance and based on the dosage. So for example, beta blockers, they can be scored either 0, 1, or 2. 0 is if you're not on it at all. 1 is if you're at a dose that's less than 50%. 2 is if you're at 50% or more. And then that can also guide something else, which is carvedilol and bisoprolol. It's only 3 titrations to get them to a goal dose. So the maximum for carvedilol is 25. Your starting is usually 6.125. If you prescribe them at starting dose, your next up titration, you're already at 50%. You know, bisoprolol, the target dose is 10. If you start at 2.5, your next up titration, you're already at goal. So kind of that can be something you can think about, you know. Metoprolol, the goal dose is 200, and your starting dose is 25 or 12.5. So you're very far from getting there. So that's one way. And then you look at the ACE ARBs and RNAs, you can go up to 3 points there. If they're on Entresto, it's 3 points. So what we did, we actually did that project here, and we kind of looked at all the patients' discharge metrics, and we scored them based on that rubric. And we found actually most of our patients were at a score that's lower than 5. 5 is kind of the arbitrary cutoff based on the study that was done in Japan. And what we actually saw was patients who were at a score of 5 or more had a 50% less likely to be readmitted in 30 days and in 6 months. And when we actually looked at the ischemic subset, that number was 80% reduction in 30-day readmissions. So that's kind of an interesting way you can do. The advanced heart failure team, they're using that score in their notes, so that's a number that you will always see. The interesting thing about the score also is you don't need to be on all 4 medications. You can be just on 2. But if they're dosed appropriately, then you're already at that good score of 5. And again, not all of your patients are going to be able to tolerate GDMT. If you have an end-stage renal disease patient, it's going to be just almost impossible, you know, because most of those medications have EGFR cutoffs. But yeah, I mean, the manuscript is published, so I can share it with you if you want to kind of read it and look at it. I'm actually going to present it in Florida chapter ACC because we won a quality improvement award there. We won a grant. So yeah, I can share all that stuff with you.
Right. Any other questions? I guess we're good. Thank you.